Hello everyone. So today we are going to see about the next bundle, which is the VAP bundle, or we call it as the ventilator associated pneumonia bundle. So before going into the bundle, let me explain on what is VAP. So VAP is nothing but it is a ventilator associated pneumonia. So this is where the patient is developing the inflammation of the lung parenchyma when a new device is being assisted onto the trachea through either through the endotracheal tube or through the non-invasive mask or might be through the tracheostomy tubes. So this is mainly the pneumonia which is occurring less than 3 days, that is from second to third day after the endotracheal tube intubation has been done, or might be on the patient is on a continuous mechanical ventilation. The possible risk factors would be microaspirations due to sedation, supine position prolonged, that is not properly following the semifowler's position in order to drain the secretions, and subglottic secretions where there is no chance for removal of secretion by using the suction, and presence of NG tubes, and in case of any comorbid condition, that is multi-organ dysfunction failure, and might be patients with a known case of COPD, ARDS, or head injury. And if the duration of ventilation is on a prolonged days, aged client more than 60 years of age group, and poor infection control practices in and around the ICUs or wherever the patient is on ventilator, and stress ulcer prophylaxis not in place may be a major risk factor for developing. So the VAP is mainly being transmitted through the might be due to improper insertion of the that is the endotracheal tube during intubation, or might be not following after the intubation, that is not maintaining the position of the patient, not frequently suctioning, not going for the bundle. The common causative factors would be on early and late onset. So the early onsets would be the early onset of VAP would be due to Streptococcus pneumoniae, Haemophilus influenza, or Staphylococcus, because these are all community acquired organisms. And the late onset might be Pseudomonas, Acinetobacter, Bomani, and E. coli, Klebsiella, methicillin resistant Staphylococcus aureus, because these are usually replace the patient's normal flora, and that is leading to hospital acquired infection. So the common diagnosis would be like they follow three criteria, which is clinical criteria, radiological criteria, and microbiological criteria. In clinical criteria, if the fever is there for prolonged, it is more than 38 degrees Celsius, leukocyte counts, that is the WBCs, are very much elevated, and the amount of tracheal suctioning is more increased for the patients, and oxygen levels are very much reduced, SpO2 levels as well as the PaO2 levels in the ABG are reduced. And in case of by doing a chest x-ray, we can see the infiltration around the lung parenchyma, which is denoting the pneumonia. And microbiological criteria, that is we can identify what is the growth of the bacteria. So each is giving 2 score, and if a patient is going to receive more than 6, which indicates the patient is having VAP. So the general strategies to be followed is that conduct an active surveillance for VAP, and always see that our staff nurses, that is we, going to maintain the hand hygiene as being published by the CDC guidelines and by the WHO, and CDC is nothing but the Center for Disease and Control. Use non-invasive ventilation whenever possible, and avoid the invasive ventilation such as ET tube insertion or tracheostomy. Minimize the duration of ventilation, might be you're not going for more than 3 days. Perform daily assessment of readiness when we can wean the patient from the ventilator and remove the ET tube. Educate the healthcare worker who care for the patients who are undergoing for ventilation. Prevent aerodigestive colonization. That can be done by doing frequent oral hygiene when patient is on oral intubation by using chlorhexidine oral rinse. And you can use all these new sophisticated brushes where it is very easily to scrub up as well as it prevents the aspiration. And we need to focus that the patient is not on antibiotic administration. As I told you earlier in corticosteroids, and that is it is going to prevent the resistance. And short course antibiotics can be planned according to the patient's condition. Minimize the contamination of equipment, that is whenever possible we are going to rinse the ET tube by using the suction catheter. Always use a sterile water and see that you're going to use a closed suction drainage, and remove the condensate from the ventilator circuits. So that is the C circuits will be filled with so many droplets. See that those droplets should be removed very frequently and it should be emptied. Keep the ventilator circuit always closed during the condensate removal, and change the ventilator circuit only when it is visibly soiled or malfunctioning. Store and disinfect the respiratory therapy equipment properly. Preventing aspiration is that non-invasive ventilation whenever possible can be initiated instead of ET. Semi-recumbent position, that is as you can see on the picture, the head of the bed should be elevated at least to 30 to 45 degrees centigrade, degrees, and then avoid unnecessary manipulation of the ventilator circuit. Drain the ventilator circuit condensate and avoid patients transport very frequently by using those drain tubes, and prevent accidental extubation of the patient because that can be a high risk for aspiration. And see that whenever we do the in-situ feeding or peg feeding, not to overfeed the patient, so avoid gastric over distension. Subglottic suctioning can be used to prevent the VAP. So the VAP care bundle states that head and elevation 30 to 45 degree, sedation, vacation, that is we're going to give some space for sedation and we are going to see the orientation of the patient. Peptic ulcer prophylaxis, that is ranitidine or PAN can be initiated. Deep vein thrombosis prophylaxis either by using the Flotron pump or TED stockings or by using prophylactically through medication that is apparent. So daily sedation is that you're going to stop the sedation every 8 o'clock in the morning, and then we see how is the command, that is eye, verbal and motor response. Of course verbal response is impossible because of the ET tube on place, but we can assess the eye response and the motor response and then we can continue. So to conclude, VAP bundle must be initiated everywhere whenever the patient is on non-invasive as well as invasive ventilation, and see that we frequently do the subglottic secretions, and endotracheal tube is well cuffed and placed in position to avoid decreased ventilation or hyperventilation. So these are the possible assessment questions of VAP. And that's all for today. Thank you.